I'm going to present the targeted approach to diarrhea after the transplant using a new technology that we have adopted, that is a film array. So the structure of my presentation is that first of all, we'll try to see and identify what's the problem, why we actually started looking at it, how we were looking at it, what are the patients, methods, results, conclusion, and most importantly, what are our limitations. So the diarrhea post-transplant, I'm sure all the people who are working in transplant units would realize it's a big problem that we face. So if we go through the data, it is pretty scarce. There are just a couple of publications. At the maximum, I could find about 5, 6 of them. So in one of the largest cohorts that was published, that was in 2012 or 2010, if I'm not wrong, in the European Journal of Hepatology. So out of 302 included patients, they found 10% as diarrhea. And most importantly, they said that the maximum, that is 80%, presented within the first 4 months after the transplant. So if you go beyond the liver transplant scenario, we look at the BMTs, we look at the renal transplants, they report a much higher percentage of 13%, going up to 45% in the BMTs, probably because they use a much higher immune suppression protocols. The etiology, which has been broadly discussed in all these publications and also in one review which I could evaluate, is the most common thing is the CMV, Clostridium difficile, and cell sept induced. So though I would advise a word of caution against cell sept, because every time repeatedly it comes to the fore that we really don't know how cell sept, that is MMF, actually causes diarrhea. Secondly, CNIs have been implicated. There have been off and on reports about Campylobacter. There are more and more reports coming about norovirus. There have been anecdotal cases of adeno and more so of rota. The other ones are pretty much down the line. So what we got new in our hospital is a Filmarray stool panel. So it is like a nested multiplex PCR test. It just takes about 15-20 minutes to run. It does not have a user dependency, so it can be done at any time of the day. You just need a 2 ml stool sample in a Carrie-Blair medium, which is put in like an ABG machine into the system, and about 10 minutes later you have a report. Normally it detects 22 microbial organisms by a PCR. So the list is here, and it mostly covers the most common diarrheagenic organisms. So we thought that, okay, let's try to see what's the etiology of our diarrhea in our post-transplant patients, and surrogately we will also come to know what's our incidence of diarrhea post-transplant. Secondarily, we wanted to see that can it actually help us in having a better antibiotic stewardship. And lastly, does actually MMF need to be withdrawn or not withdrawn? So these were the primary aims and the secondary aims that we started with. We started to include only the children, because I do pediatric hepatology, and we tried to include them at least up to 4 months post-transplant. So we included between May 2017 and May 2018. We identified diarrhea as a loose watery stool more than 3 times per day, or if it was higher than usual for before, but in fact most of them, all of them had more than 3 times a day and persisting for more than 2 days. So we excluded pre-existing IBD because we would not know whether that's a flare or not. We excluded overlap, that is AIH and PSC, and AIH and UC. We excluded any child who had a pre-known celiac disease, or because we also had one child with a short gut, so this was a later on addition that we will not include short guts either. So the stool was collected and processed as per the manufacturer instructions. The Filmarray PCR was done. At the same time, we always did the CMV and the EBV PCR. The patients, on the basis of the reports, were divided into 2 groups, that is the infectious and the non-infectious diarrhea. So in the inclusion period of those 12 months that we wanted, we performed 29 liver transplants for children. 9 out of these 29 actually developed diarrhea. So if we see, it is 31%, which is much higher than what has been reported in other liver transplant units. So infective diarrhea was in 6 out of 9, non-infective was 3. The onset was at a median of almost 3 days, versus the non-infective was at the onset of almost 8.5 days. We've not tried to implement any test of significance as the numbers are very small. So if we just look into the micro profile, we find that the single infective organisms were found in 5, and one of them had a mixed infection. So if you go look into the single infective organisms, bacterial were 2, that is a EIEC, enteroinvasive E. coli. Surprisingly, we had 1 Vibrio. The viral were 3. There were 2 of rotavirus and 1 of adenovirus, the one which causes diarrhea, that is 4041 strain. The mixed infection had a mix of astro and EPEC, that is the enteropathogenic E. coli. So it's just a description of what we found, so we can actually come down to the conclusion. So we find that the viral organism profile is actually more in our limited cohort that we could see. We actually find more rotavirus than has been reported in other transplant centers, because we did not find similar data coming out of Indian transplant centers, maybe because we are more endemic for rota. The similarities were the presence of astrovirus, adeno, and also noro. Noro I have not shown in the data, but we recently found one. The bacterial organisms, we were very surprised to find a Vibrio. There was no Clostridium difficile, which kind of goes in line with the other reports which are coming out of Indian centers, and we could actually implement a better stewardship. So the limitations are that new onset diarrhea attributable to organic causes, but we actually miss because we only did the stool PCR or the Filmarray post-transplant. So we really don't know what was the scenario pre. Is it actually the immune suppression which has caused an overgrowth, or what else? We really don't know that because we don't have paired samples. It was a non-randomized to withdraw the MMF, so we really can't comment on the MMF. So our secondary aim number 2 was abandoned because of a study design deficit. The luminal presence to mucosal presence is something which is theoretical, that are these organisms just present inside the lumen, or do they actually cause a mucosal defect and diarrhea? So are they just innocent bystanders, or they actually cause something? Thank you very much, and I would like to address any questions.
I mean, nice small study. Sharath, well done. I struggle with the most important thing is having that pre and post data, because you have to define what a carrier status is and what an infective status is. If you cannot define that, then I think, you do not know what to do with your data.
Exactly.
That's a comment more than a question.
So with these 2 study design deficits of the cell-sept withdrawal and the missing paired data, so we've just used this as a pilot, and we don't plan to publish it in any case. So we have implemented the study design changes for the next upcoming proper prospective trial that we are doing.
Nicely presented, for sure. The exclusion criteria means you try to exclude IBD, ulcerative colitis, etc. Are they not at risk of infective nosocomial infections? And a test like this, if that's positive, would change the approach to manage those patients? So I don't understand the reason for exclusion criteria.
So the reason for excluding these patients was very simple, that we just wanted a pure cohort in which we presume that they would not be infected before. They would not have other causes of causing diarrhea. So if you have an IBD, they are definitely more likely to have other infective diarrheas as a predisposing factor. So we wanted to exclude them so that we just take new onset diarrhea.
Actually, for your next study, I would include them, because these children are more at risk from the diarrhea. Yes, they might have an underlying diarrheal illness, but if they get something like rota or norovirus, they are more at risk from their liver transplant than the other children. So please give due consideration for including them in your next study with properly pre and post. Because if you have pre and post, then including them in your next study will be key to answering the question of the impact that they would have on the post-liver transplant outcome. Thank you.
That's a valid suggestion. Thank you.